Hello everyone, welcome to my channel. I am Kavya. Today I am going to talk about pulmonary assessment. First of all, we will talk about the objectives or goals of this assessment. It helps us to recognize and for better understanding of respiratory anatomy and physiology, to appreciate components of respiratory assessment, to identify the approach of respiratory assessment and priorities, to discuss diagnostics and monitoring to aid respiratory assessment. Component of pulmonary assessment. Number 1. Primary survey. Immediate intervention is required in emergency situation. Identification of gross signs of respiratory compromise, for example, evidences, hypoxia, level of consciousness. Second, clinical history. This includes chief complaints, allergies, past medication history, past medical history, last menstrual period, event leading to present situation, social history. Signs and symptoms include dyspnea, chest pain, sputum production, and cough. Third, physical examination. This includes measurement of vital signs, inspection, palpation, percussion, and auscultation. In inspection, visual assessment is required, while in palpation, it involves using touch to gather information. In percussion, by striking the chest to determine the state of underlying tissues. By auscultation, entails listening to and interpreting sound transmission through the chest wall. So let's talk about physical examination in detail. The first component is measurement of vital signs. Here I am talking about the normal vital signs in an adult. Number 1. Heart rate or pulse rate. It should be between 60 to 100 beats per minute. Second, blood pressure. It should be equal or less than 120 by 80 mmHg. Third, respiratory rate. It should be between 12 to 20 breaths per minute. Temperature from 96.8 to 99.5 degree Fahrenheit. Last, oxygen saturation. It is denoted by SaO2 and it should be between 90 to 100%. Second component of physical examination is inspection. In general inspection, we observe body build, level of consciousness, agitation, speech, skin color, and exercise tolerance, if possible. Second, head and neck. In this, position of head, nasal flaring, and breathing pattern are observed. In breathing pattern, mainly nasal versus mouth breathing. Third, thorax. In this, symmetry of chest wall movements, dimensions of chest in AP versus transverse diameter, use of accessory muscles, pattern of breathing, evidence of trauma, wounds, deformity, scars, and alignment of spine. Extremities. In this, clubbing of fingers, oedema, and peripheral cyanosis should be observed. Third component is palpation. We palpate the structures of neck and thorax to identify abnormalities. In neck, the position of trachea. In thorax, we compare left with the right side for tenderness of soft tissues, for edema, for expansion of chest wall, for tactile fremitus. As the name suggests, tactile means touch. We ask the patient to whisper 99 and therapist will touch the patient anteriorly or posteriorly on the chest wall to feel or observe the resonance on the chest wall cavity. Fourth component of physical examination is percussion. It is used to help in assessing underlying structures of the chest wall. In normal lung, the usual sound is resonant or hollow. Dullness or dull note is present if consolidation is there, and it is of medium in intensity and pitch. Hyperresonant or tympanic sound. It is present in cases like pneumothorax or asthma. It is of high in pitch as air traps inside the lungs. Flat note. It is present in cases with large pleural effusion. The last and important component of physical examination is auscultation. Auscultation involves listening over the chest wall as air enters and exits the lung. To perform auscultation of the lungs, a stethoscope is placed firmly on the patient's thorax anteriorly, laterally, and posteriorly, and the patient is asked to inspire fully through an open mouth and then to exhale quietly. Now we will talk about the breath sounds. Normal breath sounds heard over the chest are tracheal, bronchial, bronchovesicular, and vesicular. Tracheal over the trachea, bronchial lateral to the sternum, bronchovesicular over flat bones like sternum and scapula, vesicular over lower lobes and posterior segment of the lung. Abnormal sounds are present if there is a pathology. Crackles are of two types, fine and coarse. Wheezes is like a whistling sound. Rhonchi is like a snoring sound. Pleural friction rub is like a sound made by walking on a fresh snow. I have linked the audio of these sounds in my description. Except the breath sounds, we also auscultate for respiratory rate, depth, and rhythm. Thank you.